and thanks for hanging in there for the afternoon. As Jamie mentioned, I work with Rob at the Colorado Consortium for Prescription Drug Abuse Prevention. Previously worked here in the AG's office many years ago when we initiated some of the litigation, and it really is quite rewarding to see where we've come right now. And a lot of kudos go to the legal staff, to the lawyers in this department who have really worked hard across multi-state district litigation to get us to the point. You saw all these funds that are on this billboard over here, to get these funds to come here. But one of the first things way back when that we wanted to make sure happened, and a lot of credit goes to Attorney General Weiser and to the staff, is we wanted to make sure that the majority of the funds got out to the local community, because it's you folks at the local level that are really working to address the problem. But not only that, but we need to be respectful of you folks thinking about the solutions you need to match your needs in your community. Not for the state to think they know what we need, but for you, so appreciate that. Now, the consortium has a broad network of providers. We cover a lot of different strategies, but keep in mind that as you're learning here, you might be thinking that your community also needs to learn. So if you want some help with that, that's where the consortium can help you. So I'm hoping that many of you have met our external relations staff. Jamie is a former external relations staff person, but if I could get those staff to stand up, you may have seen these folks. Are you over here? So here are the folks. So this is Lindsay Simbe. Lindsay, raise your hand. Lindsay, wave your hand. And she's been working with you all in the Northwest. She lives in the Northwest part of the state, and she's working with you all there. Jessica Eady, raise your hand. There's Jessica. And she lives in the Southwest part of the state, and she serves the Southwest part of the state. And we have two new folks helping us out right now. So Kristen Carpenter. Kristen, raise your hand. And Kristen is helping us. She lives down in the Southeast and helping with the Southeast quadrant. And then one more person who's helping with the Front Range North and the Northeast is Jennifer McInder. Raise your hand, Jennifer. So these are folks that, if you're not connected to, I hope you are, can connect you so that we can follow up, because maybe you want to take some of this information and share it at the local level, and we can help you do that. Thank you all. Appreciate that for the good work you're doing out there. Now, the topic at hand. One of the more challenging topics sometimes is this topic of risk reduction. You've also heard it called harm reduction. But I have to tell you, folks, is that this is one of the more important strategies to be thinking about when you're looking at your funding at the local level. Certainly there are state resources, and we want to make you aware of what those resources are when it comes to harm reduction or risk reduction, so that you don't duplicate your funding over what's already available. But there will be gaps, and we want to work with you to help fill those gaps when it comes to working with this population, because what we're talking about here are two very important things to keep in mind. Maybe there's a third too. One is meeting a person where they're at, a person who has an opioid use disorder. Where are they at? Not all these folks are ready for treatment. Now, we want to make sure that treatment's available so that when that opportunity they come up and say, I'm ready for this, we can get them there. But in the meantime, probably the most important thing to do is keep these folks alive. Keep them from further harm, whether that's any other disease, but keep them alive. Now, what does this take? So we have a panel here of 4 folks, all with experience working with high-risk individuals. You're going to hear from someone with lived experience as well as currently working in that. You're going to hear from a physician who's in emergency rooms working every day with folks who are overdosing. And then you're going to hear from 2 individuals who have worked in the field out in Colorado, but have brought that knowledge now to the state level to help us navigate state, manage systems and funding and get it out the door. But what I want you to keep in mind is that when you hear the word risk reduction or harm reduction, I want you to substitute that in your mind, and maybe even in the language that you educate your community. And I want you to think compassionate care, because that's what this is. You got to reach in your heart, you got to find the compassion for another human life, and then if you don't quite get that compassion up into your mind and your head, get educated. Learn about this and bring that compassion into the mind and into the work that you do so that we can help these folks, because treatment works and recovery works. So with that, Maggie Seldeen is our first speaker.
Thank you so much, Jose, for that beautiful introduction, both to me and the subject at hand. My name is Maggie Seldeen, and I am the founder and director of High Rockies Harm Reduction, a nonprofit organization providing free Narcan, Naloxone, fentanyl test strips, safe use equipment, syringe disposal, first aid and wound care supplies, peer support, overdose prevention education, and so much more in our Western rural communities. Thank you so much. I'm also a person in active and sustained recovery and an affected friend and family member. I grew up in rural Colorado in the communities that I serve. I lived in Denver for a year. I went to college in Grand Junction, so there are still towns in Colorado I've never heard of before. I'm very well aware of that, but I consider myself kind of a child of the state. Not in a bad way, in a very free and good way. I've been floating around all over. Sorry, anyway, I gotta stick to my script here. So I had a lot of experiences firsthand growing up with these things, and so I know how real these issues are in our communities. I grew up in what's considered a very wealthy community in a home of violence, addiction, and neglect. My existing family are mostly people in recovery or active addiction, and I lost my mother to a heroin overdose in 2006 when I was 15 years old. Her story has been told 1,000 times, if not more, in our country. She went into treatment in an attempt to get out of a court case, and the first time she used after leaving treatment, she relapsed and died because she was not used to the strength after that period of abstinence. So I'm very, very passionate and super honored and privileged to be here in this work, in this field, and working alongside so many passionate and amazing individuals, and truly to be doing this work at such an exciting time on a precipice of a lot of change in how we deal with mental health and addiction issues. I wanted to go a little even further on my personal story and say I was expelled from an alternative high school my freshman year and was completely criminalized and blamed and sent to drug and alcohol classes, sent to therapy, sent to all of these mandated things, and nobody took the time to look at the fact that I was living in a house with drug dealers. So we need to take a really holistic approach, and especially youth is my passion. We need to look at all of the protective and risk factors that are going on, because I think that's kind of where we've been, is accusing individuals, this morality, this blaming, and we're moving towards more compassionate care, right? It wasn't the courts, it was some of the therapists, but it was none of those mandated things, none of the people who told me, you need to change, you need to quit, you need to get better, you're not going to be anything, you're not enough the way you are. None of those messages helped me. They just pushed me further into my use and further into my addiction. The people that helped me were those who loved me unconditionally and accepted me as I came and gave me space to stabilize. I truly believe that substance misuse is a symptom of mental health issues 100%. We use because we cannot cope with reality for whatever reason, whether it's because we were born with something a little different in our brains, or because we are not used to working from home 24/7 and we're about to kill our partner and our pets, because it's just gotten that far. So we need to look at these mental health issues and real evidence-based programmings and services and helping people at that individual level, because that's what's going to get our people over this hump. That's what's going to get us people into self-actualization and living their best life. I digress. I could talk all day, but I think I was given a very short amount of time before I hand this off to some amazing professionals in this field who will have a lot more interesting data and exciting slides for you, I'm sure. But I wanted to talk really briefly about what we're seeing on the ground level in, kind of our most common things we talk about in terms of opioid use disorder specifically, but substance misuse in general. So Narcan, drug checking, and syringe services are kind of our hot topics. In terms of Narcan, we have come a long way in a short period of time to now schools want Narcan. Parents want this information. Public health wants Narcan. Narcan or any form of naloxone should 100% be in every first aid kit and every medicine cabinet in the country. It can't hurt anyone. It can only save lives. Why would we not have it? I was really pleased to speak to a group probably like a quarter of this size last week, and everyone in the room knew what Narcan was. And I think that that is due to the amazing work by groups like the Colorado Consortium for Prescription Drug Abuse Prevention, by CDPHE, and so many people on the ground and systematic level getting this information out there, but we still have a long way to go. This year, we were introduced to Cloxato, the 8 milligram nasal spray, which is very similar to Narcan, but twice as strong, which can work wonders in terms of the fentanyl epidemic. But we're still having a lot of resistance because people are just now getting used to Narcan. I still have people think that this is a controlled substance. I still have people that don't know that it's safe and legal to use even when it's expired. And we still see people all the time that don't know that it's safe to call 911 to report an overdose. And unfortunately, with the Fentanyl Accountability Act, that's going to kind of undo some of that work, because now people are going to continue to be afraid to call 911. And the problem is, it doesn't matter what the law is, it matters what their understanding of that is, right? So we've done a lot of great work, but there's still a ways to go to really make sure we're getting Narcan, Naloxone, Cloxato, whatever version of it is, out into more and more hands. I think we all know some of our communities are better at this than others, and it's my hope that we can really kind of blossom this from the communities that have been front runners in this and take it to every community in Colorado and the nation. Then we have drug checking. Everyone wants fentanyl test strips, which is awesome. What are you going to do with them is my number one question. Where are they going? Fentanyl test strips are great. They are a great means of risk reduction because it gives people a little bit more control over what they're using, but there is a lot of margin of error for these, and no one should ever get fentanyl test strips without Narcan. A lot of people, they don't want the Narcan because they're trying to test their cocaine or their MDMA. They don't use opioids. Exactly, that's why I want you to have the Narcan, because I don't want you to use opioids either. But the problem is too many people are being accidentally exposed. I want to do a quick plug that if you go to highRockiesHarmReduction.com, we have a 5-minute how to use Narcan and a 5-minute how to use fentanyl test strips and written instructions for the fentanyl test strips, which I find more effective than handing out pieces of paper explaining something that I know someone's not going to remember, because it took me 4 tries the first time I did it before I was even like, oh, I should probably read the instructions, right? So we've done a lot to try to make sure people are out there using these right, but there is still a wide margin of error. And drugs, chocolate chip cookies, so this part of the drug doesn't have fentanyl, great. You could still overdose on a lethal amount of fentanyl in the remaining part of the pill or powder. So they're a great step, but they are not a fail-safe. Nothing is 100%, and certainly not fentanyl test strips, because there are just a lot of problems. The next bastion would be laser drug checking. There's a lot of conversations around this, but that kind of leads me into what I'm seeing with syringe services, which is who is going to bring me their drugs on premises to test them? Anybody here? Maybe? And that's a hard thing too, because we kind of get used to, like, even when I was someone on the streets, I had nothing to lose. I'd go in and get anything. I'd talk to anyone about what my experiences were. But that is not the norm. And most people who use drugs are not people who live on the streets, are not people in indigent housing. They are people with resources who have a lot to lose. And that is really where the benefit of fentanyl test strips is greater, because our people on the streets, we should just assume that everything's fentanyl. But we still have a huge community of people recreationally using cocaine, MDMA, ecstasy, all sorts of things, from our college students all the way up to our seniors who recreate in Aspen. I've seen them, they know how to party, and I want them to be able to party safe, but there's still a lot of work to create like this awareness that we are all affected, that everyone should carry Narcan, and there's still so much stigma. I want to just give you one quick piece of data, which is that in 2017, the Colorado Health Institute identified that 75% approximately of people who were in need of help for substance use disorder were not seeking the treatment they needed for fear of shame, stigma, and being, shown to be an addict or whatever that means in their community. That was up from about 50% of people who needed that help in 2015, and these are pre-pandemic numbers. So we need to do more to meet people on the streets. They are not coming out for services, whether it's syringe services, therapy, treatment, whatever it is. They are not coming to us. So my next plan is to get mobile units. We've been doing satellite services and community-based organizations, and it's not enough. So whatever I can do through mobile units to get out and meet people where they're at. We are super lucky in Colorado to have access to a lot of free supplies through the state, such as Narcan. And when you are a registered syringe service program, you can get access to other free supplies, but we still need people. We need bodies. We need to make these jobs sustainable for folks and sustainable for folks with lived experience. So we need to focus on salaries, sustainability, and mobile services. Thank you so much.
Thanks, Maggie. If you are not familiar with your harm reduction organization that works in your area, let's get you familiar with that. You need to know who these folks are, find out what they're doing, what supports do they need, what's being covered, not what's going on. So please, we'll help educate you on that. So let's hear from some of our state partners. So Sam Bourdon, come on up and give you a chance to talk about the state.
Thanks, José. I have to follow Maggie. Jeez Louise. Thank you so much, Maggie, for talking about harm reduction and bringing your passion forward. Like José mentioned, Sophie and I are both ex-direct service harm reductionists, but we still brought our harm reduction to our paper pushing up at the state. So we're going to talk to you a little bit about the services that we provide on a state level. Harm reduction is not new. It's been around for a long time. It was created by people most affected by the harms in the world. We're all vulnerable to harms in the world, and I would guess everybody in this room wants people to have safe, healthy lives. And so you're all harm reductionists. Yay! So at the state level, what we know is that nothing exists in a vacuum, including substance use disorders and mental health. So the branch that I work in is called the that's Sophie's, never mind. Violence and Injury Prevention Mental Health Promotion, and I am in the Overdose Prevention Unit. And so we really work to address the biopsychological, social aspects of what causes injury and harm in our communities, especially focusing on that substance use side for us. And I don't think I have, oh, I do, cool. So we are also in the Prevention Services Unit, just to make things more confusing for y'all. So you heard some data about overdoses in our community. In 2020, we lost 1,477 people to overdose. That includes alcohol, opiates, methamphetamines. That is likely an underestimate. And the reason for that is because we don't have the ability necessarily to do toxicology testing for every death that may be substance use related. And so what we're trying to do at CDPHE is really expand the capability of coroners to do that additional testing for opiates or other substances so that we can really direct our efforts and make sure that we're working towards helping those communities most affected. So we do these kind of mini grants that are about $5,000 throughout any community in Colorado. You can contact us and we can get you set up with a plan to get you started on that partnership with the state. It definitely is a helpful way for us to get folks' stories out so they can get funding and communities can get the support that they need. Another program that we have in the Overdose Prevention Unit is the COSAP grant program. That is the Comprehensive Opioid Stimulant Substance Abuse Prevention Program. It's through the Bureau of Justice Assistance. So this is a federally funded grant that we received at CDPHE, and it now funds 4 different rural communities in the state of Colorado. So those folks are working on building recovery services in the state, building up treatment services in the state, really trying to address substances across the different continuum that folks may be engaging with, not just opiates necessarily. We know stimulants continue to be an issue, especially in our rural communities. I'm sure many of you are familiar with our Naloxone bulk purchase fund. This is a fund that allows eligible entities to access Naloxone at no cost. And so that includes schools, law enforcement agencies, community-based organizations that serve people who use drugs. We actually had an expansion of eligible entities, so I'm not gonna read you this entire list because that'd be a little boring, I think, for everybody. But as you can see, we're gonna have a lot more access for folks to that Naloxone bulk fund, and hopefully that'll help with the proliferation of this life-saving antidote to different communities. All right, we also have funding through CDC for the Overdose Data to Action Fund. That funds 11 different communities across the state to address overdose and substance use in various different ways. So that might include surveillance and data, that might include overdose prevention, that might include provider education, peer support. Different communities can choose the different intervention that works best for them. And we're seeing that happen across the nation. So we're really lucky to be able to have 11 communities in Colorado participating. All right, and this is my program, so I can speak with a little bit more pride, I think, because it's kind of my day-to-day. So the Harm Reduction Grant Program is a state-funded program that was enshrined in statute in 2019. And basically, the original intent was to make sure that we were building bridges between law enforcement, public health, and harm reduction. Now, these are three areas that haven't necessarily always kind of been able to collaborate effectively for various reasons, but they're also three areas that have the exact same goal, and that's to make sure that their communities are safe and healthy. And so our goal was to build those bridges and to make sure that we were also reducing harms associated with drug use. Harm reduction, we know, is an effective strategy that's been around for decades. And as Jose said, it's very much based in compassion and reality and justice. And so we're trying to make sure that folks have access to that across systems. Recently, the program changed a little bit, and so it's going to be focusing more broadly on multiple different efforts for reducing overdose and preventing harm. So it won't necessarily just be those three different systems, though we hope that those communities continue to work together. We have 6 different grantees funded as of today, and that funding will continue to be appropriated. It's state funding, and hopefully we'll be able to provide these services going forward for a long time. We also received an expansion of funding, so we should be releasing a request for applications fairly soon for additional projects across the state. If you have questions, please feel free to contact me, and I will pass it off to Sophie. Ooh. Where's Sophie's?
Go. Let me make it over to my slide here. Oh, I'm gone. Keep going. There we are. Sorry, y'all. Hi, everybody. My name is Sophie. I use she, her pronouns. I'm the Drug User Health Coordinator over at Colorado's STI, HIV, and viral hepatitis. That means that I focus very closely within the bounds of disease prevention in our communities. My background is in harm reduction. I was a direct service provider here within the state of Colorado and the city of Denver. I'm slowing down. I know I'm fast. I'm excited to be here, and most of that reason is because I've gotten the pleasure to work with a lot of you before. In my role at the state, I provide a lot of technical assistance and subject matter expertise to internal and external partners. A lot of you might be familiar with somebody in my office that I work with very closely, and that's our disease intervention specialist team, or our partner services. They provide outreach and support to people living with HIV, either currently or newly diagnosed. We're expanding that into viral hepatitis, and we are focusing very closely on syphilis and congenital syphilis cases across the state. What might not surprise you is a lot of folks who are either testing positive or living with those infectious diseases also report some type of substance use or are somebody who uses drugs. In my role at the state, as I already mentioned, I have the pleasure of providing subject matter expertise around rapid and confirmatory testing for HIV, hepatitis, and other types of STIs. But the true gem of my role is being able to work very closely with the 20 syringe access programs we have across the state of Colorado. That's right, I said 20, which is really exciting. We are rapidly growing and expanding, which means that our community partners in our more rural areas especially are really embracing harm reduction, are embracing syringe service programs, and really understanding something that Jose brought up earlier, which is meeting folks where they're at. Understanding where somebody's at and helping them identify their own needs and giving them the tools to succeed in whatever way feels the most realistic for that individual. A wonderful harm reductionist named Dan Bigg, who started the Chicago Recovery Alliance and is the reason that many of us, or maybe all of us, have naloxone today within the United States, often said that any change is positive change. And that's the type of work we do in harm reduction, is recognizing the value and worth in everybody in every part of our community, and also recognizing the actual steps or types of support that somebody might need if they are using drugs. In addition to that, we're able to provide support through our training unit, which we have a plethora of different either in-person or virtual trainings that you can take, and this is all aimed around doing better in your clinical roles, doing better in your work at the state. How can I better serve people who use drugs? How can I better serve somebody who's living with HIV? What if I wanted to bring rapid HIV testing to my community? And I know what you're thinking, why is she talking about HIV and all this testing and things like that? And that's because The continuum of care for people who use drugs includes rapid testing. It includes access to sex education. It includes referrals to treatment. It includes talking about food security and housing security. And what's really incredible is the only places that we have who adequately do this for people who use drugs across the state really are syringe service programs. While we have people who use drugs intersecting with clinics, with our hospital systems, nobody is meeting people where they're at like our SSPs are. And they're able to provide linkages to care and engagement with community members that we don't have in other spaces. And through partnership with those syringe service programs, and hopefully the expansion beyond 20 programs throughout the state of Colorado, we're gonna be able to create more continuum and I should say a better and more positive continuum of care for people who use drugs in the state. This was already mentioned a little bit by Amy Cooper earlier, and luckily I'll get to dive into it a little bit more, and that's because we have the pleasure of working in partnership with the Behavioral Health Administration to administer state opioid response dollars. We are that lovely bucket of harm reduction, and that means that I've been able to run our fentanyl test strip procurement program for the past 4 or 5 months since April. We are really excited to report today to everyone in this room that while right now only syringe access programs are eligible to access those fentanyl testing strips, we're going to expand directly to local public health agencies. This would mean that you would get in contact with me and I would be able to send directly to your agency at no cost boxes of fentanyl testing strips. I can help you with training. I can help you with engaging with community partners. I can help you with systems, whether you want them to go out to clinics or you're looking more to provide for folks that are maybe getting in reentry, leaving our jailing systems. Whatever that looks like for your community, I would like to practice harm reduction with you all. I want to meet you where you're at. If you have a syringe access program, if you have a jail, if you don't have any harm reduction supplies at all, whatever you're doing, you're already there, right? I just sent test strips out to OLAF for the farmers market because that's where they should be, in every community event, in every space where folks are gathering, because we want to provide as many opportunities as possible for people to engage with these types of tools. I'll make my email available to everybody. And like I said, we're not quite there yet, but we're getting closer. And I'm really excited to be able to expand these test strips into our LPHAs so we can get them into especially our rural parts of the state that don't have syringe access programs. So know what you're thinking. Oh, I live in a county or I live in a community that doesn't have an SSP. I want to hear from you the most. Please reach out. We would love to create access and expand access to these tools. And in the meantime, even if I don't have this one to support, I still want to hear from you. I've had a lot of success in connecting folks to vendors, best practices, and training materials for that given community, right? So one example is I don't want to give the same test strip training or training around harm reduction to youth that I would to providers and folks that are working in clinical environments. So it's all about tailoring your method and the communities that you're working with, but harm reduction is for everyone. And I'm really excited to bring the test strips themselves into these spaces, into more rural communities. And then last but not least, another program you probably are all very familiar with, it's just our CHAP program. These are MSA dollars allocated from the tobacco settlement that go directly towards HIV prevention. And so for my purposes, yes, that means PWID center services. And when I say PWID, I mean people who inject drugs, because those are the people who are most at risk of HIV when we're talking about people who use drugs. That said, we're going to include other things in that wonderful continuum of care that I mentioned. We're going to have increased access to PrEP and PEP. We're going to have conversations about SSTAF and creating accessibility for people who are currently living with HIV. But as I mentioned, most importantly, we're providing direct funding access to syringe access programs, and again, meeting that gap that we see, or the lack thereof, in funding for folks in our community. Jose's telling me to slow down again. Sorry, all. And that is because there is a federal blending block on funding, not blending. There is a federal block on funding for syringes using federal dollars. And that is why, I believe since 2017, maybe earlier, CDPHE has allocated direct dollars towards syringe procurement. And that means the other part of my wonderful role at the state is ordering syringes at no cost for syringe access programs so that they're able to effectively support their communities and prevent the transmission of HIV, hepatitis C, and other infectious diseases. And most importantly, allowing our community-based organizations to reallocate those other funds into additional services, into the salaries and the staff salaries and the rent that Maggie was talking about, and most importantly, into creating systems that support people who use drugs in our communities. Well, I'm all done. Who's kicking me off? Thanks for everyone for your time.
Thank you. Good afternoon. I'm going to rewind this a little bit to get to my slides. Sorry about that. I think I put my slides in the wrong place. Great. So hi, I'm Dr. Don Stader. I'm an emergency medicine and addiction medicine physician. I've also had the pleasure of working all across the state, both in locations urban and rural. So for Moffat County, I used to work at Memorial Craig Hospital. I work at Lincoln Health, which is in Lincoln. And I also work at Swedish Medical Center, which is right south of downtown Denver. And I bring a very medical perspective, but I also bring a perspective of someone who for the first 7 or 8 years of my career did this all wrong. So I want to ask for people who are in recovery, or people who have known people in recovery, and I think of Kristen Bates' story when I talk about this a lot. How many of those have been harmed by the medical system when you went there for help? Or how many of you have been told, oh, you're here for addiction services. We don't do that. We're an emergency department. Or we're a hospital. We don't do that. We don't start people on methadone or buprenorphine. Right? How ridiculous is that the number one killer of Americans under the age of 50, and we have a medical system that refuses to actually treat them? How outraged should each one of us in this room be that we've let this catastrophe persist? And how many Americans are we losing every single day because we've not fixed this? So another question is, how many of you do not live close to one of the 20 harm reduction through in-service programs that we have in the state right now? How many of you do not live close to one? Great. I see a lot of hands, and if you're in a rural community, that's you. Now, how many of you live close to a hospital? We have a hospital in every community across our state, in most communities across the nation. And therein lies the opportunity. The 800-pound gorilla in the harm reduction treatment epicenter of the United States healthcare system is, guess what? The healthcare system. It's the hospital, it's the clinic. It's demanding that we no longer neglect this disease and we actually start treating it. So I'm going to just talk about harm reduction, but that's just me a little bit on my soapbox. And again, for all of you who control opioid settlement dollars, I've got an assignment for you. Call your hospital in your community and ask them, do you give out Naloxone? Do you provide addiction treatment? If the answer to either one of those is no, then I think there's an opportunity to actually involve the healthcare system in creating the future that we should all be aspiring to. And that's another place that you should consider possibly putting some of your opioid abatement dollars. Now, in particular, I'm a simple person with a small, small brain. My wife will tell you that. So when I looked around and said, okay, well, Colorado hospitals and emergency departments where I work, should we be giving Naloxone to people at risk of overdose? Sounds like a good idea. Are we doing that? Oh no, we're not doing that. Why aren't we doing that? Not a great answer. So we started a very simple project called the Colorado Naloxone Project that said 100% of hospitals should be giving Naloxone to people we identify at risk for overdose in emergency departments. And thankfully, over the course of a year, and there's a lot in between here, but right now, 97% of Colorado hospitals, that serve 97% of patients, in your emergency departments give out Naloxone. We've passed 3 different laws that make this actually payable. We have 22 different organizations that help work with us. We have 6 labor and delivery units who give out Naloxone because overdose is the #1 killer of pregnant women in our state, right? And we have a year, this coming year, we're going to be dedicating much of our work toward making sure that 100% of NICUs, perinatal units, et cetera, are giving Naloxone to affected mothers and families because we have to save lives, right? Because this is something that we have both a moral and scientific imperative to do, and it is ridiculous that we have not done so as of yet. We also have a leave behind program that's actually in Moffat County, where if they show up to a scene and the person refuses transport, that we leave Naloxone behind with them so that in case the person does suffer a subsequent overdose or their Naloxone wears off and they still have too much opioid in their system, that that person doesn't die. So if you are from any one of the areas across your state and look at this map and say, well, that's a hospital right by where I live, then I'd invite you to get in touch with us and to help us coordinate with you how we can improve naloxone services for your community and your hospital. You don't necessarily have to build something new. You just have to work with the tools and the resources that you have. And finally, I'm going to end with this. So, like I said, for the first 7 years of my career, if you had come in after having an addiction or an overdose, I would go up to your bedside after you'd sober up and say, what the hell are you doing? Do you want to die? Do you want to die? Are you going to just throw your life away? I was so stigmatizing to people. And it's something that sometimes when at silent moments I still think about with tremendous regret. That for the first 7 years of my career, I went around, instead of healing people, harming people, actively making them never, ever want to come back to a hospital again, actively making them feel like they were less than human. And one of the things that naloxone does, more than anything else, is carry a message. And that message, when used correctly in the healthcare environment, where we see people at their lowest moments who have come very close to death, is give them a concrete example that they're worthy, that their lives matter, and that we are rooting for their recovery. And if we can tie that, it's often called a lifesaver, right? Throwing a lifesaver to someone in the middle of the ocean is great. No one's gonna say don't do that. But having that attached to a boat is better. So we can drag them up and we can bring them into recovery, right? And if we actually mobilize our hospitals, we can do that. We can build that system. We've done so before with so many complex diseases, whether it's cancer, heart disease, stroke, etc. Now is the time to do so for addiction. Thank you.
So give me a time check. What do we got left for some questions? How much time we got? Yes. Yeah, let's get one more. Oh, hang on. There you go. Contact information for Dawn. I am going to encourage you all, folks, several things. First of all, number one, find out who your harm reduction agency is. If you need some help with that, contact our consortium staff, or it will get you some information and find out who those folks are. Invite them into your coalition work, get to know who they are, figure out what their needs are, how can they be supportive. You're talking 18 years of funding. Some of these folks are living month to month, year to year on the grant, and even with the state funds, those funds may not last forever. So get to know what their needs are and what it could take to sustain them over a period of time. Number two, these state partners here. So you can either get a hold of them directly or, again, work with the consortium staff so we can connect you to these folks to leverage your money, because that's what we're going to have to do, folks. It will never be enough, but we want to make the best use of these opioid settlement funds leveraged against these other dollars. And do know that there are some of us working really hard to get this money available to you all. We're working at the state legislature, we're working at the federal level, we're working with national partners that we have here that spent some time with us today to continue to get those dollars. And right now, we're very fortunate to have all these ARPA funds coming, and we're going to make sure you know how to access those funds. Questions for our panel? What do you want to know? We have one over here, right behind you here. Go ahead.
So I'm from an area that tends to have a couple needle exchanges, and the community tends to push back on them because you find syringes on playgrounds that kids are playing with. That happened 2 weeks ago at a kid's birthday party that I was at, kind of thing. What kind of either information or details do you give to people in the community when they're bringing these types of things forward to counter that narrative?
Let me double check. I see some green lights on, so you should be able to speak into the mic, but this mic looks like it's dead.
Well, first and that's a common thing that we hear, and unfortunately I just had somebody the other day say, who I knew was not interested in syringe services, and I said, well, I'd love to talk to you about how these programs keep our community safe, and her response was, well, I don't believe in them, so I don't want to hear it. So that's really hard when we have people who are literally unwilling to listen. But right there, and it's interesting because this comes up a lot, I don't want a syringe service program because there's needles in the park, but I'm pretty sure my colleagues will tell you that that's what syringe service programs exist to mitigate, is needle debris. When people utilize these programs, there isn't that kind of trash. You don't find people, when we have syringe programs and safe consumption sites and all of the levels of evidence-based risk reduction programming we can have, then people are using disposal properly, people aren't overdosing in the streets, and like that is the goal of these programs. But that means there needs to be community education, both for people who use and the rest of those who are involved in these issues, that this is what we're working towards, is to mitigate this problem.
And I'll just add to if you do have syringe service programs in your community, I encourage you to reach out. They want to hear about them. In my role at the Harm Reduction Action Center, I had a partnership with 911 dispatchers. I received, not law enforcement, I received each individual syringe complaint that occurred within the city and county of Denver. And that's because when I was able to respond, that reduced the weight on our law enforcement partners, so they were able to respond to legitimate crime that was really putting a lot of fear into our communities. And in addition to that, I was able to equip businesses with training for disposal in naloxone. I was able to connect with community members in the area and have conversations about what disposal looks like. Where are my options? Maybe they're unaware. And most importantly, connect them to additional services. And so I'll say this is, syringe service programs are well equipped to deal with those issues. I'm sure they'd be happy to hear from you. If not, please let me know. I'm happy to provide training and support to any agency, because any agency that's operating a syringe access program within the state of Colorado, or really anywhere, can and should be doing that exact type of community outreach. We need to be doing cleanup, stakeholder engagement, business engagement, leadership engagement within our communities to ensure that if and when there is a problem, the person says, oh great, I'll call the syringe exchange, they'll get it cleaned up, connect with folks, and then that area is on the radar, doesn't happen again. I'm sure they're willing to reach out. If not, please let me know, and I'm happy to help out. It's in their purview, no doubt.
Another question? Someone else?
Medical detox badly out in the northeast corner. Is there anybody that would help get a medical detox? The hospitals are like, oh no, Centennial Mental Health has the money for that. Centennial Mental Health says, oh no, we've looked at that and we've decided not to do it. And everybody just sends me somewhere else, you know, and nobody wants to do it. But everybody agrees we need it. And it would not just serve like Sterling, it would, the whole Northeast could be served. The closest we have is Greeley, 2 hours away, and then you get up there and all the beds are full, or, for whatever reason you can't get in.
I can answer that question. First, the answer to the question is yes, it can happen. First, though, you got to have that political will and willingness for some folks at the local level to come together to say it's important enough for us to do this. And yes, there are resources, not only through the state departments, but there's this infrastructure pool of money, right, Heidi? You're talking about 10% infrastructure that could go to help renovate, a hospital section of a hospital. One of the best examples are the folks up in Fort Collins. I don't know who's here, if Leslie or someone else is still here, but they've managed to set up a unit as well. So yes, the answer is yes. It's a matter of, through your council, your regional boards, having the discussion, getting the right leaders together to say yes, get a location, figure it out, get a hold of us, and we'll bring the resources together to help you out. Another question? Harm reduction related? One more before we take a break. Or no, before we go to the next panel. Right over here behind us, right here. Go for it.
Hi, Laura Solomon from Gilpin County Human Services. I have a question because I didn't see Human Services in your list of people who can get things. And so I'm just curious if we have to go through public health, because our public health is through Jeffco. So it's kind of like a roundabout way for us to then get things for Human Services for Gilpin. So I was just curious.
Sure, no, that's a great question. So I would assume you're a unit of local government, correct? So you're on that list.
Perfect.
Yep.
Thank you.
And I spoke with Gilpin County EMS last week, so there's test trips coming. I got you.
I just wanted to add, because I tend to field people coming to me and then going to CDPHE or the consortium, and when in doubt, just apply for the bulk fund. And the people who work there and work at CDPHE and all these places are amazing, and will work with you to make it happen.
Great, wonderful. Thank you all very much. A round of applause for this, folks here, for coming. One more. Oh, not going forward. I've been instructed to move this forward, but it's not going.